We acknowledge the land that we're gathered on is the unceded territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. My name is Ian Becker. I'm a GP from Victoria who cares for about 50 patients in long-term care there, and I'm your moderator for this rapid-fire session. Glad you're all here. You're looking good. It's going to be rapid, which means 20 minutes for presentation and then 8 minutes for grueling questions of your presenters, so get those ready. I think we're just going to get started right away. Nick is going to be talking to us about reducing medication administration time, and then we have Alison after that. Take it away, Nick.
Thanks for joining us. That's awesome. Today I'm excited to tell you about Polypharmacy with a twist, the experience we had at Queen's Park Care Home, and the sort of the journey we've been on with QI over almost the last year. I have nothing to disclose. Queen's Park is a long-term care home in New Westminster with 165 residents. Our QI team is myself, our clinical nurse educator, pharmacist, all the nursing staff, like all of them, managers, and our awesome QI team and coordinator Simran. And the project sort of came out of a research project that my friend Janice, who's in the front, can tell you all about upstairs with her poster project, the PAPLOC study. And I won't steal her thunder from her project, but essentially we were recruited as part of this research study on how to have QI projects improving care during COVID. And it sort of inspired us to develop a QI team at our care home. And so I'm going to walk you through one of the two projects that we did. As is the way with quality improvement, you always start with sort of unpacking the problems that we had. So again, Janice's team says, do you guys want to do a QI project? We said yes, and so we got together to try to figure out what is going on at our care home, and also in the sense of how can we improve things because COVID's going on and we're having difficulties and we had so many outbreaks in our care home. So we talked to our team, unpacked the problem. The care aides really felt under-supported by the nurses. They were pretty raw and frank with their assessment. Like, we do not feel support from you. We do not feel you have the time when we need you. Like, we are fighting away here, and where are you at? The nurses felt that they spent a huge amount of time giving medications and that polypharmacy was driving this. They wanted to be there for the care aides, but they just couldn't. Like, they were spending so much time giving medications. And then the physician team really felt that, because we're sort of like the ones that prescribe the medicine. So they're like, well, why don't you do something about this, Nick? And we're like, well, we got sicker and more complex patients. Like, we're not taking easy patients anymore like a decade ago. Like, we have real tough patients. And our care home, especially being very close to Royal Columbian Hospital, a tertiary care hospital in the north of Fraser Health, we are asked to take some tough patients, many dialysis patients, complex wounds, all kinds of stuff. So we sort of had this confluence of problems, and what are we going to do to break the cycle? So I won't bore you with the drivers and stuff, but I just trying to go by the philosophy of quality improvement. We sat down and looked through what are the drivers of these problems. And the big ones were nurses were not really participating in polypharmacy reduction. One of them that we wanted to focus on was we did polypharmacy reduction at these legislative 6-month medication reviews, but that was oftentimes pharmacist, physician driven. The nurse was there, but they weren't feeling that they could really speak out too much during that. Their role was just to, give us, how often they needed set-asides for their bowels or something. It wasn't like they were active, strong participants in that. The other big one that we focused on was when the nurses wanted to share a concern they had about a medication, there was no structure to that. So you have, how many nurses do we have at our care home? I don't know, like Susan, I'm going to guess we have 100 nurses at a care home of our size probably. There's tons of nurses. And so how are they going to feel like allowed to talk to us? They're just, I'm just, an LPN having my 15, 25 patients, like how am I going to feel comfortable, telling you something? There's no rule book for them. So when we looked through all these drivers, we said, these are things that we can really target. And so that's what we did. So we had some change ideas. We thought to ourselves, why are we waiting 6 months for a medication review? Why not say, in the moment, a nurse or somebody identifies a medication that might not be necessary, why don't we bring it up right in the moment? Our care home especially has lots of turnover. We're a 40-year-old building. It's a terrible building. People come and go before that 6 months even occurs, so we can't even get to the first med review because people come and gone. So we thought about, let's do something in the moment. And then that's what it came to, well, why don't we make something more ingrained into our culture at our care home, where we bring people together to say it's okay to talk about this, and let's make it an automatic routine thing. So we came up with this idea of polypharmacy huddles. So in these huddles, we empowered nurses to work together, the 4 nurses that were on that day for that team, to talk with each other and come up with ideas of what medications could be changed and adjusted. So we thought about our measures that we wanted to sort of look into. Of course, we need the data, and we need to track if we're doing well as part of QI. So we said, as part of the, back to the start of giving back time, so the nurses had time to work with the carries, we said, let's track the time it takes to administer medications. And then we also saying, if we're going to empower nurses to make suggestions, let's see how often the suggestions that they offered were accepted by the physicians. We looked at some process measures, like looked at, are there certain medications that take up more time or are more annoying to give? So we looked at that. And we also looked at balancing measures, because we wanted to make sure that we're not going to decrease the resident satisfaction and the care that they got because we're just looking at time. We didn't want nurses just to feel it's a race. Let's get our meds done in 30 seconds, and then there's backlash from residents. So our aim statement, we wanted to reduce the time it takes to administer morning medications. We chose the morning because most medications are given then, and just easiest to do when the leadership's on site to remind people. At our care home, specifically at the start of the project, the Empress Place side, we have 2 wings of 75, and we have a little small satellite unit. And we wanted to decrease the time by 3 minutes per resident over a 6-month period. And so our baseline was it took 8.6 minutes per resident to give medications. And by the end of it, we got down to that. We went to 5.5 minutes, which is huge when you think about each nurse has 25 residents. We save them, or they save themselves really, over an hour of time to be with residents doing direct care. Like, to me, this was just unreal that they got over an hour back. They could take their breaks when they wanted to. They could have their lunch. They could get their charting done. Like, they could help the care aides. They could help the residents. So we had a number of PDSA ramps. I love in our little office we have all the PDSA ramps in the back. And so when we have a new nurse or a new team member come, we sort of point to it, and I talk to them about all the little pizza pies. I go, because they've never heard of PDSA. So I go, look at all the pizza pies. This is what we've done for a year. So our first PDSA ramp was really the testing phase. And so I said to myself, can we actually do in the moment polypharmacy review? And so I went and just sat with a chart, somebody of my own, and I said, can I just chop some meds today? And I go, yep, I can. So we can prove that there's fat to be trimmed off of the medications here. And so then I said, because we wanted to empower the nurses, I said, let's grab one of the LPNs. So I grabbed the LPN and I handed her the chart, a patient of hers and mine. I said, what do you think? Is there anything that you'd want to get rid of here? And she had ideas right off the bat. I was like, okay, great. So there is some experience and expertise with our nurses that they can make the suggestions. So then we try to standardize this. So our next ramp was, we're going to have a mini huddle, which meant that we just grabbed the 4 nurses, and I just said to them, off the top of your head, you guys just finished morning rounds, off the top of your head, you each give me 1 medication you don't think is legit. And I'll explain what we meant by that in a minute. And they each gave us 1 or 2 medications. So I said, great, no prep, no education, no nothing. They were able to tell us right off the bat, here are some suggestions on medications. So that was just on the fly. So then we made it more formal. We got together in a bigger huddle that was sort of prepped for in advance. Again, we showed success with a different group of nurses. And so now we made scheduled huddles. So every Wednesday, it's going to happen in about 3 hours at 2 o'clock. The team gets together and they just look through their medications. They've sort of in the morning thought about it as they gave their medications, and they make some suggestions. They bounce ideas off each other and say, do you think this is fair? What do you think I should suggest? And they work together as a team to make these suggestions. And so we then, once we had some success with it, we standardized it, we made an SOP, and now we're spreading it from the Empress side of our facility to the Windsor Place side of our facility. And my friend Chelsea in the front said she wants to spread it over to her care home too, without even seeing the lecture. So there you go. You're doing it, writing it down now. So here's just some of our tools we used. We had a suggestion form. So when they do this huddle every Wednesday at 2, they get out their binder and they have a suggestion tool. And so we looked at what kind of suggestions can they make and they have great confidence with. So refusing that frequently. So of course, if a patient's refusing frequently, who knows that the best? The nurse that's trying to give it to them. If there's side effects that they notice, if they don't feel it's necessary any longer, and the one we always talk about is, I gave somebody Lasix for leg swelling, the swelling's gone, let's get rid of it. And it's not effective anymore, and then we gave them some other options. They notify us by putting this recommendation in our doctor book, an established communication tool we already had. They just write the little thing, patient doesn't need Lasix anymore, can you stop it, Nick? Great. And then on the far side, we have our charge nurse, because this is the LPNs who are doing the suggestions. We have the charge nurse. After I've come to do my weekly visit, the charge nurse will go through the orders and double check if I've actually listened or not. More for the tracking part, because we wanted to see if it was successful, but also because some days I'm busy and I forget to actually do all my work, so it's a double check to make sure I've actually listened. So this is our run chart. We start off at a baseline, as I said, about 8.6 minutes per resident. The first PDSA cycle, that's the mini huddles and trying it out. We had a drop. That was mostly because I was super enthused and grabbed the LPNs and said, let's stop some things before we sort of standardized it and got it running for everybody. We did find that, because we track casual nurse versus regular nurse, we did find that casual nurses, and here's one data blip, took longer. Of course, they don't know the residents as well. They're not going to be as comfortable getting through things. But as we had going through that first set of PDSA cycles and making the regular huddles, we see a quick drop down to our goal and underneath the red line. Okay, so then we had a bunch of COVID outbreaks. I think we had 6 of them. It was wild. Things got off track. They don't have time to do the huddles as much. And so we didn't even have time sometimes to do our QI meetings. So we brought that back down as we got into the last blue part of the graph. And so now we've been probably 4 months of steadiness with this, and we continue to have medication suggestions and keep our numbers down. So the other bit was, we asked people, how often do you think the physicians are going to agree to make these changes? Because the nurses were very nervous about making suggestions, especially LPNs who have not been given a lot of, I don't want to say the wrong word, but they've not been given a lot of power to make suggestions. They feel that they're just running things and not, a part of the active team. So we asked the team, what do you think the physicians are going to do? And they varied. I think 50% of the time, maybe 80% of the time, they'll agree to these changes. So I'm going to ask you guys, how often do you think a physician agreed to a change? Just throw out some numbers if you're brave. 100%. 80%. 75. Anybody less than 50%? One in the back. So I like it. So 70% of the time they accepted it right off the bat. 26% of the time we forgot to do anything, so that's why they came back. And when we tracked those 26%, again, 75% of the time we agreed. And then only 3% of the time did we not agree. Like, that's amazing that our LPNs were able to make accurate, physician-agreed suggestions 97% of the time. So we saw the ball rolling. Once they did this a few times and they saw that we made changes based on them, they were really keen to keep on doing it. So our lessons learned, to have a sustained culture change, you really need to embed it into your standard practice. I kept on saying to them all the time, we are making the weekly huddles the same importance as your RI rounds, as your care conferences, as your weekly nursing huddles. These have to be something that is automatic, that I can't call and remind you about. And they've done that. Without the leaders maybe on site that day, the LPNs and the RN get together and do it themselves with great results. So with empowerment, that's the word I was looking for. We needed to empower the nurses to feel that they are part of it and that they're actually the experts, because they deal and work with the patients directly more than I do. And we do know that polypharmacy is unavoidable. That's why I didn't talk today about 9+ medications or this or that. I talked about very practically, our patients sometimes need lots of medications. But let's make sure that the ones that aren't needed are gone. And if they need 16 meds in the end, because they're a dialysis patient with all this and that, and goals of care that they want to go back to hospital, let them have 16 meds. But if it has a side effect or it's not working, then we get rid of it. So next steps, we need to continue with our education. We have lots of new nurses coming through. We need to keep our foot on the pedal with that, and that comes at the weekly rounds. We've now standardized the process since I submitted our slides. And we've spread it over to Windsor Place, the other unit, and so we're sort of in the early days of seeing how it goes with them, but they're also finding good success with it. And so that's a really cool bit. And I'd just like to thank our whole team. I just put our names up there, our QI support team, and Simran. I think we can't have done this at all without a QI support team. I think that's the big piece that we often forget, is that if you don't have a leader who understands QI and the language and how to run a toolkit, then you're going to fail. So, yeah, that's it.
We have a microphone if you have some questions. Put your hand up. Yes. Person in the back. Oh, there's someone right behind you. So,
I don't have to shout it out. At the beginning of the slide, you said you may be able to identify drugs that were specific to, did you, aside from LASIK, was there anything else that you identified?
So one of our other change ideas that we dabbled in a little bit, but I didn't do it for this presentation, is we looked at how long it takes to give certain medications, and the big ones that spent time and the nurses felt that really wasn't valuable to them was creams, crushing medications, eye drops, and puffers. And so when we looked at, does a person really need 10 eye drops or not? We discovered maybe they don't. And this actually spurred me on to get a local ophthalmologist to collaborate with us about, when we inherit a patient from a hospital that has all these cataract and this and that eye drops, do they need them all? And he's actually like, no, sorry, glaucoma drops more. He was like, you know what, actually, Nick, I think that they probably could be pared down now that they're with you. So these are the other change ideas we have that we're going to work on. Talking about narcotics, the nurses have to run back and forth to the narcotics cover, chase people around the whole building for the narcotics key. So we're having plans to how do we streamline that as well, that reduce time for administration, yeah.
Excellent question. One at the back.
Did that also include blood pressure medications? Did you see a reduction in those?
So that's a great question too. So one of the things that the nurses have been looking at is the parameters that they sometimes have to check. It's sort of a jump off from your question, but when you have a bunch of people on blood pressure medicines or heart rate medicines, the nurses are always having to check heart rates and blood pressures. And so we targeted, do we actually need that? And then we got some blood pressure, so it took a little bit of time on the nurse's side, but then we proved we didn't need those blood pressure or heart rate medications. And we were able to bring a lot down because now we're actively looking to see if the blood pressure is at target or not. Same thing with glucose. So people are getting daily glucometer checks. We asked ourselves why, and so we pulled those people in and got the diabetes medicines to the right spot, stopped doing the checks so often, gave the nurses time back.
Great. I have one more question. Did you encounter nurses disagreeing? So sometimes we see that. So would you have an LPN put forward a suggestion, a change made, and then you've got the next one coming in?
That's a great point. Yes, we did. And so what we encouraged them, as they had that friction, like the example off the top of my head is some behavioral medications and sleep aids. And so we just said, this is not for any two nurses on the same team to disagree about. It's them simply to put forward a suggestion and let the physician and you collaborate on it. So if two nurses have a disagreeing view, then have them both bring their case forward and talk with the physician. So we did see that. It wasn't very much though in the end, but it came up a tiny bit.
Okay, thank you.
I have two questions. Did you have any unintended consequences, such as reducing the inappropriate use of antipsychotics, as one? And two, did it increase and improve the morale of the team, such as the healthcare aides?
So the unintended consequence, which we did look at as a balancing measure, was that some residents weren't as pleased because their nurse wasn't spending 8.5 minutes with them. And we have rooms of 4, it's terrible. And so 8 times 4, like they were out of the room half the way. So some residents who are very cognitively intact and chatty noticed and said to us, but we then put back to the nurses as we were learning about this, we said, you don't have to leave then. If you still want to spend time with them, spend the time. And so we've been bouncing back and forth on that. We haven't saw a real big change in our antipsychotic use because we don't have a high antipsychotic use sort of to begin with. We're, in the whatever 20%, 25% goal kind of range. So that wasn't one that the nurses often saw to reduce in the suggestions. What was your second question?
The morale, because the healthcare areas didn't feel
Yes.
supported.
So we did a little bit backwards, that we didn't quiz the healthcare aides in an objective way beforehand. We just had this, sort of session, and we didn't actually quantify it. So when we went back afterwards to sort of try to quantify it, they were just ticked off about everything because unfortunately it's pandemic time and we were in the middle of outbreaks. And so they didn't qualitatively feel a big difference, but we really felt that was because it's just a very stressful time. And yeah, so I think if in perfect world, we would have gave them an objective, kind of questionnaire beforehand and afterwards, and we didn't do that. That was our mistake.
Couple more questions yet? You can shout it out.
Actually, let's sort of back up to that question as well. One of the things that we teach our nurses is to engage the residents, right? And I wanted to know if there was, if you saw some compromise in terms of the relationship between the nurse and the patient during med administration and that reduction in the time that they were administering, because I think that's one of the times that they use to talk to the residents and whatnot. Did you see a decline?
So just in a few of the cognitively intact patients that we did interview afterwards, sort of said, the nurse isn't here as much during that morning time. But again, there will be back later if there was a clinical need. So people that are, say, medically stable that don't need much of an assessment, they lose 4 minutes of chit chat. And so they did notice that. Yeah.
One more question.
Thank you. I am a senior. I live in an independent living attached to an assisted living, and we have on our same property a complex care building. My question is kind of twofold. How often do your doctors visit? And how are the staffing rates? Are they understaffed? What does that look like in your facility?
Yeah. So our physicians visit weekly. That's sort of the standard in our community, is every 1 or 2 weeks, and they come and spend a half day. Our staffing is at licensing levels, but we could always use another 100 nurses, so if you know any, send them our way. No. Yeah, but no, I think we're not like continuously, they don't have half the staff there. We almost always, except for outbreaks and everybody's sick, have pretty close to what we need. We would love to have another RN, especially in the evenings, but we can't just find enough to staff that number. But for the most part, we're doing pretty good.
So around the staffing, I'm just curious, did you have a lot of staff that were floaters between facilities? That happened I'm from Kelowna. That was a massive impact because then trying to staff for 24 hours was just huge when they had to stop floating from one place to another.
Yeah, we didn't because of that order from Bonnie Henry that we had to have single sites. So we had our team, but we did notice that because we're a Fraser Health entity, people had to come in when people were sick during outbreaks. And that's why we had the increase in the rate when we had outbreaks. But once we got back to our routine team, and we were able to get our numbers back down. So it was successful then.
Awesome, thank you. I've got 2 questions for you.
Oh, Ian, go for it.
The zingers at the end. The first one's easy. It's just, did you measure how fast, how much time you're saving in 6-month drug reviews now? Because they're already done for you.
I didn't do that, but I'm sort of, I do polypharmacy every week when I go see my patients as I open the chart. So I'm pretty lean. Some of the other physicians aren't. So I would wonder if they're going to save a lot of time. That would be a great question to ask them.
The other one was just, I think there's probably 10 of us in the room who just want to do this now to our facility. Would you give us any advice about launching into this, just printing out a form and trying to make it happen without the QI support? Any thoughts?
I think you go back to my PDSA ramps, and I just grabbed somebody as a proof of concept. Because again, that's QI, right? One-on-one. Do the first one by yourself with one person, and then make that an impactful person on your team. one of the nursing leaders to say, let's just see if me and you can do something right now. And prove to them, get rid of 3 meds in the moment. And see if they want to, from a leadership side, invest in this. Because it took a while with, our care coordinators, our managers to say, yeah, every Wednesday, I'm going to give Nick some time. Nice. Right? And for them, they love it now, but like they are rolling their eyes at me, like, I'm going to give you an hour for QI project and I'm going to do this and that. Yeah. But we've got it running enough, as I said, that the huddles, I didn't say this, the huddles take 7 to 10 minutes, maybe less. So we're not asking for a huge amount on Wednesday at 2, because it's 7 minutes, they just do their thing. But that's because of 6-9 months of work to get them into that flow. So I would grab a nursing leader, and I would say, let's see if we can get this number down just in a moment, and then build it out from there.
Okay. So you have to find a doctor to grab a nursing leader.
Yeah.
Probably.
Yeah.
That's the way things go. Thank you very much.
Thank you.
Our next presenter is Alison. We're going to get her slides up. She's going to talk us through how to reduce transfers to ER. Take it away.
Hi, so my name is Alison, and I'm a Master of Public Health student with Simon Fraser University, and today I'm presenting on a review of a tool to reduce transfers of long-term care residents to emergency departments. And so first I want to acknowledge the evaluation team. So as part of my Master of Public Health, I did a practicum with the Fraser Health Authority with the Department of Evaluation and Research Services in long-term care and assisted living. And the evaluation lead for this project was Dr. Cleon Hamilton, and this is the evaluation team as well. As for a disclosure, as I mentioned, my partner organisation was the Fraser Health Authority, and I also received some practicum funding from BioTalent Canada. However, none of the affiliated organisations owned the tool that was under review, and as such, the integrity of the results was not compromised. So I'm hoping that by the end of this session, you'll be able to, learn a little bit about implementation science principles, as well as the benefits and challenges of using those principles. So, for context, long-term care resident transfers to emergency departments can be very disruptive for residents, and they can also set them up for hospital-acquired complications like injuries and infections. You're probably familiar with those kinds of things. Of course, in some instances, transfer to emergency department is necessary for long-term care residents, but particularly high rates of this do present a public health problem because of those, unintended consequences. So in 2015, Fraser Health saw some high rates of these transfers, and so in response, they kind of thought through, okay, are there any of these that we can avoid? How can we bring down these high rates? So in 2016, they implemented a series of initiatives, and one of those was Preview ED. And Preview ED, basically how it's intended to work is 2 main components. So first of all, it's like a resident monitoring tool. It's designed to detect early changes in health status that might then indicate a need for a transfer later on, as well as a staff communication tool. So Nick was kind of talking about the hierarchies of long-term care staff and how it's structured, and it's quite specific. And this tool was specifically designed with that hierarchy in mind, considering that healthcare aides are some of the people that see residents most frequently, and allowing them to kind of communicate to nurses the changes that they're seeing. So it's kind of those 2 pieces. So in 2021, Alison was a young practicum student, and the use and impact of Preview ED was not known, and so that kind of led to the question, what are the impact and best practices of Preview ED? Has it contributed to the changes in transfer rates? Is it doing anything else? And so implementation science was really important for this review. So I'm going to take you through a series of our evaluation framework, which are, again, all implementation science pieces. So the first piece, you might be familiar with this if you've conducted some sort of public health evaluation or program planning before, is a logic model. And so this was kind of, this tool we use to think at the system level. How do we envision, what is Fraser Health doing at a system level? How do we see that leading to our main long-term outcome, which is reduced overall transfer rates? And so if we start all the way at the inputs, these are the things that Fraser Health is kind of providing. Activities are the things that Fraser Health is doing. So Fraser Health's going in and training long-term care staff in how to use Preview ED, and also distributing resources that help long-term care homes use the tool. And then this leads to immediate output. So these are things we can tangibly kind of count. So do long-term care facilities have at least 1 staff member trained to use it? how many long-term care homes are using it. And then our short-term and intermediate outcomes are kind of the mechanisms that I was describing that through which Preview ED works. So we have increased staff. If our short-term outcomes are increased staff using Preview ED, then our intermediate outcomes are better communication surrounding transfers, improved confidence surrounding transfers, and then again leading to our overall system-level outcomes of reduced transfer rates. And so another piece, a tool of implementation science that we used was a process map. So while the logic model is thinking at kind of a system level, the process map we used to explain the granular level, what do we think Preview ED is doing in an individual instance of a long-term care transfer? How is it actually working to reduce that? And so I'm not going to spend a ton of time explaining every piece. There's a lot going on here, but I will mention, so the red components are kind of where we see the Preview ED, the tool, working. So what is the earliest point where a long-term care resident might need to be transferred to an emergency department? So we kind of thought, if you can see in the top left there, that it starts with a change in health status, which might present as a change in resident behaviour or signs and symptoms. And maybe this is observed by a healthcare aide. And then, so we have some communication channels there, and then you'll see that it splits into a 911 emergency and a non-911 emergency. And so the idea of Preview ED is to start that first step earlier in the hopes that we have more time, so it's more likely that it's a non-911 emergency, which gives us time to respond to the change on site rather than needing a transfer. And so the resident doesn't ever have to go to the emergency department. Again, this is kind of the granular level way we see the mechanisms of the intervention working. And so this helped us think through, everyone who's involved in this decision and how Preview ED works. Okay, so the final piece, this one is called the Consolidated Framework for Implementation Research, or CIFA. And so this was our final piece of implementation science that I'm going to explain today. And this one was really, while the first two components I've discussed were how we're imagining, okay, how is this working at an individual level and at a system level, this one is more about how is the intervention interacting with the setting itself and how can we measure that. So the CIFA framework was kind of invented thinking about what makes successful implementation. I think we all intuitively know that an intervention is more than just the mechanism through which it works, it's also how it interacts with the setting, both inner and outer, the individuals involved in the processes. So basically, this image that I'm showing is a visual representation created by CIFA itself. And so the framework involves 5 domains with 22 constructs, and so each domain has like 4 to 7 constructs. So I'll try briefly explain what each of these is. So an intervention characteristic, you can see intervention there. This could be things like complexity. Is the intervention easy to use? Is Preview ED easy to use? This would be different to asking, is it easy for my colleagues to use, which would be about self-efficacy, which is about the individuals involved. So you can kind of see those 2 components. And then the inner setting involves things like networks and communication. So when you need to solve a problem, who are your go-to people? And then the outer setting can involve things like peer pressure, which it's kind of interesting to think about long-term care homes competing against each other, but there is some sort of peer pressure components there. So to what extent are other organizations using this intervention? And then the process is how all of these things interact. One of the process constructs is planning. So can you describe a plan for these intervention? So those questions I've kind of been reading out are actually like provided by the CIFA framework. You can go on their website and they have a whole bunch of resources. And so basically we used this framework to help us construct our survey, which we eventually sent out to long-term care staff. We had included a lot of questions about intervention and individuals involved, and less on like the process and outer setting, but basically had some components that come under all of the domains. So, that brings us to our survey. So what we did was we created a survey and we sent it to all 85 Fraser Health long-term care homes. These are both owned and operated, private non-for-profit and private for-profit, any affiliated homes. The survey had 61 questions and took around 10 to 15 minutes to complete. And so an example of one of the questions is, I feel the Preview ED is needed to meet the needs of residents of this long-term care home. So thinking back to our 5 domains, which domain do you think this would come under? Huh? Show it again. So this question is actually an outer setting question, because an outer setting includes the, well, it says patients that you're serving. In this case, it's residents that we're serving. And so this is like, so asking a staff member this is saying, how do you see this interacting with the actual population you are serving, which is an outer setting component. So yeah, this is just one example of how you can actually implement the CFRA in a framework, in a survey, sorry. So then our analysis component involved quantitative analysis and qualitative analysis, both of survey data, as well as for the quantitative analysis, we also looked at actual changes in long-term care to emergency department transfer rates. So yeah, and that's how we assessed Preview ED. Oh, sorry. Okay, and so just to give you an idea of who was included in the survey, we received responses from healthcare aides, nursing staff, all the way up to directors of care and regional care coordinators. So we tried to get something from every point of this like staff care hierarchy who's really involved in Preview ED. And to give you an idea of the number of homes that responded, so of the 85 that we sent the survey out to, about 2/3 of the homes responded, including all 13 Fraser Health owned and operated homes, as well as 19 private not-for-profit and private for-profit homes. So, some results. So basically this is a graph showing, or a bar chart showing the changes in long-term care to emergency department transfer rates per 100 residents over the years. So as I mentioned, in 2015, we see those really high rates. And then in 2016 was when Fraser Health really responded to those. And we can see this consistent downward trend since Preview ED was implemented in 2016. But we still remain above the target rate of 30.0 per 100 residents. And so, but the main interesting thing about our results actually came from the survey and the kind of more quantitative and qualitative analysis components. So while we weren't really sure how much Preview ED is contributing to the change in transfer rates, we did find that it's a really important communication tool that helps balance staff hierarchies. Healthcare aides really valued the tool, saw how useful it was, and would say things like, "I feel heard by my peers," which is one of the really important things. And so as such, we also found that training in the effectiveness and importance of Preview ED is essential for appropriate use. So if we think back to how I mentioned we had responses across all of the staff hierarchy, staff who are further from the tool, directors of care and things like that, tended to view the tool less favourably. And we put that down to a lack of evidence or demonstrated evidence for its actual ability to impact a transfer decision. However, these are the staff that make decisions about the tool, and yet staff who are really close to the tool and using it on a day-to-day basis found that it's really valuable and see how it impacts their work, and yet they don't have a lot of decision-making power about the tool use. And so we found that it's really important to make sure that directors of care are aware of this fact, so that if they're making decisions surrounding do we use the tool or not, that they know that there might be a cost there, that it could be actually doing something else, not necessarily impacting transfers, but perhaps serving as a communication tool in some way. And I want to emphasize that without doing implementation science and kind of thinking around maybe the impact of this tool goes beyond what it's designed to do, we probably wouldn't have made this important finding. And so, thinking back to our learning objectives, I hope that you're able to recognize implementation science principles. So when you go about your next evaluation, maybe thinking, how does this intervention interact with inner and outer settings, individuals, processes, and peripheral components, as well as some of the benefits and challenges. So using this approach generated a comprehensive picture of how the tool was used and its effectiveness in a variety of settings, rather than just giving us an idea of how it impacted transfers directly. And then these are my acknowledgements. Thank you.
Questions? One at the back, one at the front, and then one in the middle.
Thank you very much for your very informative presentation. I'm very interested in this tool. I'm just wondering how, do the staff use it to interact and communicate with physicians to decide then on transfers? That's the first question. The second one is, what is the cost to Fraser Health Authority to have this tool on an annual basis, I guess? Because it looks to me like, I looked on the website, it was like a subscription process, I think.
Okay, so the first question was, do they use it to talk to how does it work as a communication tool? Yeah, so
Between staff and physicians.
yeah. So basically, Preview ED is a pretty simple tool itself. It's like a 9-question checklist that is supposed to be filled out daily. And then if there's kind of a significant change from previous days, it'll flag it, or a healthcare aide can flag it, and then they can take that to the nursing staff, who then respond to that change. And so the nursing staff might use Preview ED to then talk to a physician about it, but generally it's kind of expected that they'll conduct their own assessment. It's more of a screening tool than an actual, it's really detecting a change significantly. And then what was the second question again? Sorry. The cost. I'm actually not familiar with exactly how, in terms of monetary amounts, but I will say, so because it's a checklist, some homes use paper formats and some homes use electronic formats. And we did find that there could be, should be a trend towards using the electronic formats, because then we can have automated flagging systems. Because some of the issues around Preview ED were that, because it's a checklist that's filled out daily, it can be filled out extremely routinely, and then if a nursing staff doesn't feel that it was filled out with real thinking around what am I actually seeing, then it feels burdensome to then have to follow up. So yeah, we've definitely found the electronic format would have been better, because it's also staff found that it's also a lot of paper at times. So those are some of the resource costs. I'm not sure about the money costs. Yeah.
To the front.
Hi, thank you. So I'm a new clinical operations manager at one of the Fraser Health owned and operated care homes. And looking at ED transfers is one of the quality areas we will be focusing on. And I'm just wondering, is there opportunity to see the feedback at a site level? So for me to look at what did the staff say about Preview ED and the uptake at my care home now, and then if we do some more focused efforts. So just wondering, I guess, is there opportunity to kind of build off of this and the information that you have?
Yeah, so in terms of the specific home responses, we did some home-to-home comparisons, mostly surrounding is there a difference between Fraser Health owned and operated homes that use the tool versus private homes that use the tool, and things like that. So, I mean, you can read the report. I'm not sure where it is in the H drive, but if you chat to Janice or myself, we can find it for you. I did also create a 1-page infographic for another care home. Yeah, unfortunately, I'm not sure I can speak to how each specific care home found the tool itself, and but there were some explanations of differences across region by local health area and things like that, and included in the report that you can definitely take a look at.
Great,
Yeah.
thank you. That would be very helpful.
Yeah.
Thanks.
Very front.
Hi, thanks very much. I'm just picking up on something you mentioned toward the end, which is that the higher up you seem to tend to go in the hierarchy, the let's say less favorably the tool is viewed. And you indicated that might be because there's a lack of evidence, but I guess I'm just curious what sort of evidence you feel there is lacking or they'd like to see, because in that bar chart you presented, it seems like you've had a 50% reduction over the last 5 years, which seems pretty good. So I'm just wondering what else they'd like to see.
Yeah. So I will mention that with the bar charts, there have been a lot of things that have gone into that overall reduction in rate, and even towards as we get to 2020, there is a lot of revamping that was done to do with COVID as well, and so that has impacted our results. I think something that would have been, so basically the Preview ED is designed to detect is designed to prevent 4 different types of transfers due to congestive heart failure, dehydration, pneumonia, and UTI. And so something that would have been really, really helpful for this review, I think, is to actually break down, separate transfers into reason of transfer. Unfortunately, we weren't able to get I was only with Fraser Health for that practicum for 11 weeks, and we weren't able to figure out enough kinks in the data to have that to display. One thing we did compare was our homes that, very, very crude, I guess, outcome measure was our homes that are using Preview ED today, more or less likely than homes who aren't using Preview ED to have meet the performance target. And we didn't find any statistically significant results with that, but I will say that when it was first implemented, homes that used Preview ED tended to outperform homes that weren't, and then it was a slow, basically, until they were pretty even by the end. And so that kind of to us told us that maybe like training is really important. When it was first trained and introduced, that was when it had the most impact. So I think that what staff would like to see is literally tracking like every transfer and what was done. But of course there are limitations on our time and resources. So I'm not sure how feasible those kinds of things are, but if there was some way to display, okay, this transfer decision might have been impacted by Preview ED, because as I mentioned, it's mostly just a screening tool. These decisions are not ever going to be made by a tool like that. So yeah, just better tracking basically. But yeah, this is kind of what we were able to generate from our data.
Other questions? Uh-oh, yep.
Just to go back a little bit, with the most in place in all of our care homes, we are getting a lot of family and resident-driven transfers to the hospitals, despite their most in place. In your survey or your data, have you looked into how to change that in terms of communication with families and how the homes are all doing it? I'm sure they're all doing it differently. We obviously have the care conferences to review their most, but at the time of the emergencies and whatnot, changes in condition, the fear and all of those factors fall into place. And so even though medically they may not need to be transferred, it does occur because of such fear from the families of losing them, perhaps. Was that ever taken into account, I guess?
Yeah, so this was a really strong theme that came through in our qualitative data, as well as just in conversations with clinicians about kind of the findings, what we found in this one. And so I didn't really discuss it today because at the end of the day, Preview ED can't really impact that. But for context, when a transfer might be necessary, but they're on like do not resuscitate orders and things like that, then it's not always appropriate to transfer a resident regardless of like how medically necessary in the moment it could kind of be deemed to be. So I would say that that's kind of a component was kind of beyond the scope of this specific evaluation, but I will say that a lot of our feedback was kind of around how important family education is. So like some of our questions were just like, are there other initiatives that like kind of are competing with Preview ED? Like what else can we do to reduce these transfers? And that was one of the big ones that came through, was educate families and make sure that everyone's on the same page and consistently on the same page, because sometimes the most is in place and they will have this like order of do not send to hospital, and then the moment arrives and it happens anyway, and that's the right of the families, right? So but when I'm thinking back to the process map though, like these decisions should always be made with a conversation with the most responsible practitioner as well. And so it's just making sure that there's enough education going on and that it's happening enough on a regular basis. But I know that long-term care is dealing with a lot of other problems. So it just comes to time and resource constraints.
Thank you.
It's time for my questions.
One more.
One more. Okay.
Yeah, just one last question. Where did you get the figure of 30 from?
Figure of 30. Where did you get the figure? Where did you see 30?
That was on the bar chart. Bar chart?
Oh, so that's the Fraser Health target for I guess system level transfer rates. So 30.0 per 100 residents.
So typically, in Fraser Health key performance indicators, they either go for a national standard or there's not one. I think they take the average of the worst 10 care homes and try to want to beat the worst 10. So some kind of design thing that someone comes up with.
Some thought.
I didn't come up with that one.
So I learned about implementation science. Who here knew about implementation science before this lecture? A little bit. Wow,
Oh, okay,
yeah, it was
well,
totally new to me. And so I learned lots, thank you very much. But this very interesting thing that happened that you didn't talk about at all is how did you get, 30 care homes filling out a question, and it was 63 questions. I was like, 60? No way, you'll get 0. And she got like, hope so. Implementation science, was it work? I thought she just gave out cookies, but I imagine she put her big brain to work. Is there any secret to how you got that many questions answered by that many facilities?
I can't really take credit for that. That was definitely, so the evaluation lead, Dr. Cleon Hamilton, I think his strategy was to send it to directors of care and then rely on them to send it out. And he had a pretty specific, I think that was like 3 times reminders. We actually did get quite a few responses even after the first round of sending it out. For context, we had 295 complete responses, which was anyone who filled out at least the first question. So yeah, which we were really happy with, to be honest, like considering the burden long-term care was under at the time, summer 2021. So I would say email Clay.
Some sort of personal persuasion plus implementation science, the new mystery of how to get things done. Thank you very much.
No problem. Thank you.
Task for you guys to fill out evaluation forms so you can tell our presenters how amazing that was. And then once you're done that, you get to leave, I think. And you can go upstairs to get lunch. No problem. Just leave the evaluations on your chair or hand them in to the person in red at the back.